Okay, we're just going to go through just a quick review and we'll just use these bullet point items that are on your PowerPoint: structure, hemodynamics, and then regional vessels. So we'll go through just the bullet points for each one. And then as you have questions, feel free to ask. So as far as structure goes, you should know to begin with, and it's not listed here though, the 3 layers. You should know that all of the vessels, except capillaries, will have the 3 layers. 3 layers being the tunica externa or tunica adventitia, same thing. That will be the more connective tissue component. There's the tunica media, which is a smooth muscle component. And then there's the tunica intima, which is the endothelium, also known as endothelium, and it's the innermost layer touching the blood. The classes of blood vessels means what are the types of blood vessels, and we can go through them from leaving the heart. The first class of blood vessels that we enter are going to be known as the elastic arteries. All the large arteries are our elastic arteries. They're the ones that have a lot more elastin with their collagen in the tunica externa and tunica adventitia. The benefit of that is that it allows for the vessel to distend laterally so that between beats, while the heart is filling with blood for the next beat and the heart's not physically pushing blood out during the time, the recoil of these large elastic vessels will maintain forward flow. So their function is to maintain forward flow between beats. They do that because they have more elastin and they're considered elastic vessels. So that's the story for the first segment. Then we branch off into muscular arteries and smaller arterioles, but we'll lump them all together and we'll just call them muscular arterioles. Those guys will be significantly smaller, but significantly greater surface area in the sense that you might have an elastic vessel coming down to like 100 muscular arterioles. And so there's many more, even though each one will be significantly smaller. Their size to their smooth muscle content in their tunica media is what determines overall blood pressure. They are our main resistance vessels. That means they have more smooth muscles. So not if you were going to scrape it off compared to the larger elastic arteries. They have smooth muscles in their tunica media. But the muscular arterioles, the amount of smooth muscle that is in their tunica media compared to their lumen size, or where the blood is going through, is very, very much, there's much more. The proportion is greater. So therefore, when those muscles constrict or dilate, it has a greater impact on how much of that vessel is going to be open or closed. Compared to a large elastic artery, it's really not going to change the diameter or radius very much. So there's a greater range of change in these muscular arterioles. Therefore, their dilation or constriction status has a more profound impact on total systemic blood pressure. So blood pressure actions like the angiotensin II hormone is going to affect primarily those muscular arterioles. It's going to cause them to constrict. That's going to lessen some of the downstream flow, feeds back onto the heart to say we need to now drive more, greater pressure to push through. So whenever you have something that opposes flow, like resistance in any of these constriction vessels, and we'll talk about this when we get to the next section of hemodynamics, you have to push harder. So so we just went through the elastic arteries, but the function of the muscular arterioles is that they are the main determinant of overall blood pressure, whether it's a dilation or constriction state. That is by virtue of their mass of smooth muscle. Does anybody remember the other action that it does or function? Has to do with the pulsations. What is it doing to the flow?
It dampens the flow.
Exactly. It dampens the pulsation. So you have these surges every time the heart constricts and beats and pushes blood out. Then you have the elastic arteries, boinging out and then releasing, recoiling and allowing forward flow. So you're seeing these surges, pressure surges, because of the heart ejecting blood. So because of the smooth muscle, it's a bit softer, and in a sense, it absorbs some of that, some of those pulsations. So when blood leaves these muscular arterioles and are heading down into the capillary beds, it's steady flow. So it enters as pulsatile flow, but it comes out as steady flow. And then you can go into the capillary beds. Then capillary beds. So the structure of the capillary beds is such that there's no tunica adventitia and there's no tunica media. There is just the tunica intima or endothelium. So it's one cell layer thick. Its main function is to allow for diffusion. So we have glucose and oxygen that's getting delivered out to the tissues in the capillary beds. Fluid can also escape. There is vasomotion, which is actually a constriction and dilation of the precapillary sphincter muscles, that are normally meant to divert flow, like more flow to one capillary bed, maybe less to another. But their motion actually causes a little bit of flushing, if you will. That's helping the diffusion component, and it kind of alters a little bit of the hydrostatic pressure there. So that's a minor point there, though. So the structure of the capillary bed is that you have these little cells that are just butted up very, very closely together. If capillary pressure is really high, those cells can kind of separate and you have more fluid oozing. Or if the downstream pressure is high, maybe the venous pressure isn't very low, venous pressure might be high, and the incoming arterial pressure, so there's less of a gradient, then you may have more oozing and pooling of blood out into the tissues. So you want to make sure the structure of these continuous capillaries, the cells are nicely tightly adhered to each other. Let's see what else we have. You should know about anastomoses, capillaries, and collaterals. The veins, we have venules, which are now draining fluid out of the capillary beds on its way back to the heart. Veins have and venules have all three layers: tunica externa, tunica intima, and media, and then tunica intima, but in smaller proportions, because the veins are in a much, much lower pressure. You don't need to have the amount of integrity of the vascular wall as you do on the arterial side. So you have blood coming back, but because by that time you have got blood that is coming back at really low pressures, and in cases of it coming from the legs and returning to the heart, it's going to go against gravity. So we need valves in here. So the valves are made of tunica intima material, and so they push up very easily, but they don't allow for blood to go back down. So they prevent any backflow. And so that's one of the unique structures of the venous side, and it's low pressure. I think that kind of covers everything. So when we talk about classes of blood vessels, it really, I'm trying to address, and I have test questions that will utilize that term. So I want to make sure you understand a class of a blood vessel means, is it elastic or muscular, those categories of them, and then what their unique feature might be. So if it's elastic, distension, maintaining forward flow, muscular, more smooth muscle compared to their lumen diameter. They're going to determine blood pressure, as well as go from pulsatile to steady flow. Capillaries, one structure, only one layer. Veins, all three layers, but have valves and low pressure. So that would kind of be the summary of that. Any questions from that? Okay. So the hemodynamics is the part that makes everybody's skin crawl, usually. Here, so if you don't like it, you're probably in good company. So it's a way to just get you to understand the numerics of and the quantitative aspect of blood flow, to at least to some degree. So blood flow variables, it's as simple as it can be in a sense of what makes flow. You have a pressure gradient. You're pushing from one, high pressure to low pressure, sort of like a stream going downhill. That just gravity and that elevation is pressure. Pressure from one end to the other end. So that's flow. So the pressure from the arterial side, say if someone's blood pressure is 120/80, you start from the left ventricle to the aorta at 120 millimeters of mercury through the whole circulation, and at the right atrium, you're back to zero again. So you have downstream, even though you're coming to the same location, tube-wise, it's farthest away will be where the lowest pressure is. So obviously that's the pressure gradient. So that's going to drive flow. Now the opposite is going to be resistance. What's obstructing flow? What's getting in the way? What's going to impair flow, if you want to think of it in that context? There are three factors that will affect resistance. Who can name these three factors? Vessel length, so how viscosity, so the sludginess, and then the vessel diameter or radius to the power of, which is to the power of 4. So that means the radius is actually the most important one. It's also the only one that we're really changing in our body. It's not like we're changing vessel length, and on a regular basis, we're really not changing viscosity to any significant degree. So it happens to be the one that we can have an impact on anyways. And so that's really what I was talking about with regards to muscular arterioles, that there's more smooth muscle to cause that radius or diameter change, which is going to cause, to the power of 4, a profound impact in resistance, which means just think of resistance as something obstructing flow, if you want to think of it in that way, something that's going to make it harder for flow. So if you have greater amounts of resistance or something that's impeding flow, that feeds back eventually to the heart to say you have to push harder, and that's why our blood pressure goes up when the resistance increases, because now the heart has to push harder to get through, to send the blood through these types of obstructions. Then you should know about the arterial blood pressure value meaning. So if you recall, we had the aortic or arterial pressure waveform, this, and so if someone has a blood pressure of, and we'll make up a number, say 145 over 90, not doing too well, but so 145 would be up here. Let's write 145. Go. What does that mean? I'm telling you about the heart or about the body. Yeah, so it's the peak pressure the ventricle developed. That's your peak ventricular pressure, would be 145 millimeters of mercury. And at this junction, we're at 90 millimeters of mercury. And what does that tell you? The what? Exactly. So how much pressure that left ventricle had to generate just to open that aortic semilunar valve just to get blood even started to go. So that tells you 2 things about the body. It's not just a number, that's what's giving you information. And so then, what is pulse pressure? Yeah, so it's the difference between these two. So it would be the diastolic, systolic minus the diastolic. That's pulse pressure. And you should be able to calculate mean arterial pressure, which would be the diastolic blood pressure plus the pulse pressure divided by 3. And then you can be able to calculate that. Factors affecting tissue perfusion, that's more like cardiac output. How are you pushing blood out? How is the tissue getting blood? So one example would be hypoxia. If you all of a sudden start working a muscle, if I just, grabbed a barbell or dumbbell and just started doing some bicep curls, and all my biceps are now needing more oxygen because they're making more ATP. So the hypoxic environment, meaning that it's actually extracting more oxygen out of the blood because of the ATP generation, that is actually going to locally vasodilate, cause more blood vessels to open so I can deliver more oxygen. So working muscles can actually increase their own blood flow at a local level. But you can also have more systemic issues where you have, flight or fight enacted, sympathetic nervous system. You can have increased delivery to your muscles before you even started running in anticipation of running because of the flight or fight mechanism being enacted or diverted from other places. So that's another example of some variations in tissue perfusion. The baroreflex. Now we have baroreceptors, meaning pressure sensors, in lots of places throughout our body. And we're going to talk about some specifically, well, we actually did in this unit, besides the one here. The ones that, with regard to the baroreflex, are specific to the carotid sinus at the bifurcation of the common carotid artery and the internal and external carotid arteries. That is where we have a baroreflex that'll be elicited because that reflex is intended to protect the brain so we can maintain steady flow to the brain at all times. And so if you have too high of pressure coming up into your brain, then the baroreflex would then have an action that would do what? What would the result or the function of the action of the baroreflex be? Decrease heart rate and vasodilate. So you would have really a parasympathetic response if you have high pressure coming up that's sensed by the baroreceptors. Now, if you had low pressure that these baroreceptors sense, and in order to maintain steady pressure to the brain, what would the baroreflex action be? Vasoconstrict down there, and in systemic vasoconstriction, and heart rate will be increased. So you're going to have more of a sympathetic nervous system response. So just remember when we're talking about, you'll see this on the test, you want to look at it when we refer to, there's a baroreceptor that just senses pressure, but a baroreflex implies you have this action as a reflex. What is that action going to be? So it's usually a counter action that's going to fix it in this case. So if you have high pressure, the reflexive action will be things that are going to, mechanisms to lower pressure to balance it up. So the blood pressure hormones, we did know about 4 hormones. The first one I'll tell you about is the only one that will lower blood pressure. Does anyone remember that one? Yep, atrial natriuretic peptide, also known as atrial natriuretic factor. Either one, depends on what book you're looking at. So atrial natriuretic peptide is one that comes from the right atrium, and it's released when the right atrium gets stretched out because of high blood volume. And so if you have too much blood volume, it stretches out the right atrium and it tells the kidneys, maybe you should pee out some more volume because we have too much in our body. So it's a diuretic. The other 2 are antidiuretics. Who can name those 2? Not that one. Antidiuretic hormone and aldosterone. Those 2 target the kidneys and retain sodium, which ultimately is intended to retain water. So we'll get into the details of those when we do Unit 4 and we talk about the renal system. But in the case of antidiuretic hormone, that comes from where? Posterior pituitary. And aldosterone, which comes from where? The adrenal cortex, yep. Adrenal gland and the cortex specific region. Those target the kidney, retain water, so they increase blood volume, and by increasing blood volume, that will then also increase pressure. So it's kind of a double whammy there. What about angiotensin II? Where does that come from? That one's got a little, yep, so that one was not really meant to be a trick question, but it was not just one location like the others were. So this one involves a few steps to generate it. So yes, so that's why I think we got mixed answers in here. So how does it start? Low pressure, the kidneys are like, oh, not enough blood pressure coming in here. So the kidneys release renin. So renin goes out in the circulation. Renin combines with angiotensinogen to become angiotensin 1, and then angiotensin 1 is on its way back, goes into the right atrium, right ventricle, up and out into the lungs. And in the lungs, what happens? It goes into via angiotensin converting enzyme, goes from angiotensin 1 to become angiotensin 2. And then it leaves the lungs, and it does it in other places of the body, just so you know. It's not only the lungs, but the lungs has one of the higher concentrations of this enzyme, angiotensin converting enzyme. So then as it becomes angiotensin 2, it goes through the pulmonary veins, back into the left atrium, back to the heart, so via the left atrium, left ventricle, and now out the aorta systemically. And now you have a very, very potent vasoconstrictor that's going all over the body. And it's going to target media of muscular arterioles and then cause them to do major vasoconstriction, reduce their radius, blood pressure shoots up right away. So 2 of the most major blood pressure medications affect this particular system. Those 2 medications also have pleiotropic effects, which means they have a few other positive effects that are not always directly related to these. So that's why some of their benefits go beyond just the renin-angiotensin system. But for our purposes here, we'll just kind of keep it in the box. Who can tell me what one of those medications are? ACE inhibitors. So ACE inhibitors, so ACE, angiotensin converting enzyme inhibitor, stops the formation of what? Angiotensin 2. So you have a lot more angiotensin 1 because you're converting less over. So that's an ACE inhibitor. Then what is the other one? An ARB, exactly. So an ARB means it's an angiotensin receptor blocker. So you make angiotensin 2, but now you plug up the receptor systemically so that it's not as effective as it otherwise would be. And those are a newer class of drugs than the ACE inhibitors are, but also very good. Okay, any questions on that as far as hemodynamics go? Blood pressure? Okay. Vessel names, locations, regions, or organs served or drained. If you're talking about one being an artery, if it's serving it, or draining it, that'd be the vein side of things. So the context that you're going to see these would be, for instance, on the multiple choice portion of the exam, it would be obviously descriptive. So it might say something like blood in the thigh on its way to the toes. It's going away from the heart, so it's going to be a artery, and therefore popliteal artery. So then the same question could be blood in the thigh on the way back to the heart. Then it would be the vein, but then we're looking at external iliac vein. And so it's just a matter of just being more descriptive regionally of what it is, where it's going. So you know, is it an artery or is it a vein? And just kind of knowing the body part locations. On the practical exam, you'll need to know it like whether there's a diagram. So for the online folks, their diagrams are going to be limited to what's on those worksheets where they're more regional pictures. Some are cadaver pictures, some of them are colored pictures. For you guys in class, you're going to have more of an overall body diagram like we did on the board, where it's going to be more black and white, less zoomed in regionally, but just kind of an overall body one. So you'll be able to tell if it's an artery or vein because you're going to need to look at the heart. And if you see like an aortic arch, obviously with the branches coming off, then you know you're going to look at the arterial tree. If you're seeing the heart and that's kind of two are coming on the one side, then you know, oh, that's the vena cava coming in. Then you know you're looking at the venous kind of set. So that would be the way that you would discern it without having to stick with red or blue kind of thing. The other context that you'll need to know vessels would be a descriptive sense of you writing them out. One vessel to the next vessel, if I were to say, hey, blood going to say to the right ear or the left thumb or the right toe, where it's kind of going to different body parts. So if we go to the right ear, it would be, you know, aorta, brachiocephalic trunk, right common carotid artery, right external carotid artery, you know, ear capillary, since we didn't name any smaller vessels beyond that, and then right external jugular vein to the right subclavian vein, to the right brachiocephalic vein, to the superior vena cava, and then to the heart. So that would be or the left arm, you know, the left thumb, we would say, you know, aorta, left subclavian artery, left axillary artery, left brachial artery, left radial artery, and like thumb capillaries. And then you would pretty much name them back. The only exception coming back is that then you have a brachiocephalic vein on the way back. So it would be kind of remembering when you have or don't have brachiocephalic veins, especially if you're dealing with obviously the upper body. If we go down to the toes, then it's a matter of knowing which iliacs. That tends to be the more difficult one, I think, for some folks. I'm trying to blank lines back. But you have to remember whether it's a labeling diagram or even the written out ones, right or left. You can do an R or L without, as abbreviation is okay without penalty. And you have to write artery and vein on every one of them. And you can write a little A or a little V as an abbreviation also for those, to save space if you want to do that. But don't forget that, because that is knocking off points. So you definitely have to do that for each single one. It is repetitive, but it's a easy way to lose points, and that would be a sad way to lose points. Know about regional areas. For instance, you should know some of, like, for instance, the hepatic portal vein. You should know that it is stuff coming from the abdominal cavity, like intestines. You've just absorbed stuff, and like the spleen, it's all coming to the liver for filtration first before then it dumps into the hepatic vein and then inferior vena cava. So know that the hepatic portal vein is bringing blood to the liver, where just the hepatic vein is leaving the liver but back to the inferior vena cava. Who can tell me another vessel that's bringing blood to the liver? But in this case, it would be oxygenated blood. The liver. Make this little triangle, and we have from the guts and the spleen, lots of places coming in to the liver. This was the hepatic portal vein, and then the clean blood leaves the liver by the hepatic vein. It's going into the inferior vena cava. The other vessel that brings blood to the liver is just hepatic artery. As we're coming from here, what other, it's coming from the celiac trunk. So while we're here, the celiac trunk branches, we now know hepatic artery, but what are the other two branches off the celiac trunk? Yep, so we have the splenic artery heading off over there to the spleen, and then the other being left gastric, going to the stomach. That's right there. Good. Other regional things would be like the brain arteries, like circle of Willis. For instance, you have the internal carotids as well as the basilar bringing blood into the circle, but they're not part of the circle. Then you have the actual circle of Willis, where you have the posterior cerebral, starts it off, posterior communicating, anterior cerebral, and the anterior communicating. That's actually the circle. So you should know the circle of Willis vessels, which is different than vessels serving it. And you have a question that asks you to distinguish between the two. Definitely need to know about the fetal circulation. So you should know about umbilical artery vein. You should know about the bypasses. You should know about when the vein's coming in to the liver. You should know the foramen ovale, that it's going from the right atrium to the left atrium. You should know about the ductus arteriosus, going from the pulmonary artery to the aorta. Ductus venosus, also, you've got that coming from the umbilical vein to the liver as it brings blood into there. So you should know that.